So 84 years, this was the case, question which was asked in the previous exams. The questions are like this. The questions are not framed in the form of arrows. They are given in paragraphs, and investigations are also given in side boxes. But for comfortable, for the sake of understanding, I have framed it in the form of points. So let's see one question. 84 years, female. So always try to focus each and every detail that is given, because every detail either brings us to a diagnosis or excludes some other diagnosis which are there in the options. So here 84 years, female, right? Age is important. Always age is important. In every question, age is given in MRCP exams. So complaining of forgetfulness, and for 84 years later, forgetfulness is very common. So general physician started her on haloperidol for this agitation few months ago. Haloperidol was given antipsychotic for agitation. So after she developed forgetfulness, she became increasingly confused for a few months. Recently, odd movements she has developed on her face, arms, and legs. 2 weeks previously, she has stopped haloperidol, but still she remained confused, and the movement disorder has worsened. There is no other medication history. On examination, the mini mental status, not mini mental, it is just mental test is 4/10. Vitals are normal. Yawning movements of mouth and occasional tongue protrusion. Semi-purposeful movements of arms and legs. Increased tone, cogwheel rigidity is present. You must be knowing what cogwheel rigidity is. If not, we'll be discussing. CT scan of brain revealed generalized cerebral atrophy and calcification of basal ganglia. Right. From this question, what are the important points? She's an elderly lady. After taking haloperidol, she has developed some movements on her face and legs. Though she stopped haloperidol, still the movements has worsened. This is the history. And examination has shown that mental test, the score is decreased, and the movements are like yawning of mouth, tongue movements, protrusion, and taking it back, semi-purposeful movements, involuntary movements, and some kinds of rigidity like cogwheel rigidity and increased tone. So what do you think? What are the differentials? What differentials do you think of in this case? What can we think? So an elderly patient complaining of these things, what can we understand? Differentials. See, usually any rigidity and increased tone, all this in a elderly person suggests diseases pertaining to Parkinsonism. We have seen what Parkinsonism actually is. Parkinsonism in an elderly person. So these Parkinsonism-like features after taking medication like haloperidol, which is antipsychotic, or any other medications which decrease dopamine. See, few medications are there like antipsychotics, antidepressants, and seizure medications. We'll see what medications are there exactly. Those medications decrease dopamine. What is happening in Parkinsonism? There is decreased dopamine. This is the main pathophysiology behind Parkinsonism. That is what happening after taking few medications like haloperidol. So this is nothing but drug-induced Parkinsonism. So any case scenario where something like this is given, a history for an elderly person who has been presented with complaints of Parkinsonism features after taking some medications like haloperidol, and for example, other case can be given, a 50 years old male who has been taken for a surgery for hernia, and he has been given halothane. Post surgery patient is presenting with these complaints of, on examination these things are seen. That is nothing but drug induced Parkinsonism. So let us see which drugs cause drug induced Parkinsonism. Most and most commonly in the exam of MRCP, many year exams have given antipsychotics in the question, haloperidol, and antidepressants like amitriptyline, because it is very commonly used, amitriptyline. These medications are commonly seen in the question. Afterwards, if patient has these features, that is nothing but the diagnosis over, drug-induced Parkinsonism. But the question is not over here. For this question, the main question was, what is the treatment? The treatment for Parkinsonism because of Parkinson's disease and Parkinsonism because of drug-induced history is not the same. So this is the twist that is in the question actually, right? So let us see few drugs which cause drug-induced Parkinsonism. Anesthetic agents. So they give a scenario of hospital setup. In an anesthetic setup, patients can be given halothane. Patients can be given opiates, post-operative pain, and patient develops those features. So that is nothing but drug-induced Parkinsonism. Antipsychotics or antidepressants, like we have seen haloperidol or amitriptyline or bupropion. Few medications, these are sufficient. Not everything we need to remember. And a patient who has first episode of history coming to the casualty, and after patient has given some anti-epileptic medication, over a few days patient has developed Parkinsonism features. The medication is nothing but carbamazepine. So these type of questions can be framed to ask regarding drug-induced Parkinsonism. And a question can be framed like a 56 years old male patient who has identified with arrhythmias, has been treated with amiodarone, and over a period of 3 months, patient has come with abnormal thyroid hormone reports. Along with that, there are abnormal movements noticed in clinical examination. So these abnormal movements are nothing but Parkinsonism manifestations of amiodarone. And TSH is obvious. Sometimes it is deranged because of thyroid can be hypo or hyper, which can be discussed in cardiology classes. So a question can be complicated. Question can be framed like this. Few things can be given regarding amiodarone toxicity, hypo or hyperthyroidism, and Parkinsonism like features. So we have to remember these medications which are framed accordingly in the question. Okay. So cardiac medicines like amiodarone. You can remember these things that so far this can be sufficient. Majorly antipsychotics and antidepressants. These are usually given in the questions. So what you have this question now, how to evaluate the case? The first thing you have to evaluate is when you have suspicion, as in this case, after starting haloperidol, patient developed these complaints. What? So you have suspicion that it is drug-induced Parkinsonism. Next thing you have to do is stop the drug. This is the very important rule, because after giving so much a big question, you easily identify that it is drug-induced Parkinsonism. What is the immediate treatment protocol is the question that is asked, and you have to choose this option, stop the drug, not the treatment part. We usually give anticholinergics, which we discuss. We should not choose that option, anticholinergics. We should choose stop the drug, because it is immediate treatment of choice. These kind of tricky questions we usually face in MRCP exams. Read the question properly. What is the ultimate or treatment of choice is different. What is the next immediate treatment that is available? So immediately what we do is stop the drug. If the drug like amiodarone, for example, patient is on amiodarone, we cannot stop the drug. So question yourself, can we stop the drug or not? If it is amiodarone, we cannot stop. If it is non-amiodarone, like say haloperidol, we can stop and we can replace with other medication. So yes, we can stop. So when we cannot stop the drug, we cannot stop. What to do? Just see what are the abnormal movements. Patient has come with tremors. Are the tremors hampering patient's daily quality of life? Yes, they are dealing. No, they are just simple movements and they're not affecting the quality of life. If they're not affecting, just observe the patient. No need to do anything. If they are really worrying the patient, then what we do is we do a scan, DAT scan. I think we have discussed in the last class, SPECT, single photon emission CT scan. In that we measure the dopamine activity, that is DAT scan. So do a DAT scan. When do you do a DAT scan? When patient is suspected to be having drug-induced Parkinsonism, and the drug, if it cannot be stopped and the abnormal movements are hampering the daily activities of life, get a DAT scan done. DAT scan. If it is positive, what does a positive DAT scan mean? It means dopamine activity is decreased in brain. So that indicates it is not drug-induced Parkinsonism. It is the dopamine itself is decreased in the brain. I think the last image, if you can remember, if it is positive, that means the dopamine activity is decreased. That indicates Parkinson's disease, and you can straight away start the treatment of Parkinson's disease, that is giving levodopa and combination therapies. So DAT scan. If DAT scan is negative, that is dopamine is normal, but still patient is exhibiting features of Parkinsonism, that indicates the drugs are affecting the activity of dopamine. So at this point, just decrease the dose. If you cannot stop the medication, just decrease the dose. And if even after decreasing the dose, if you cannot control, just refer to the cardiology. Or if it is amiodarone, refer to cardiology. If it is some other medication which is very necessary, refer to that specialty doctor for further altering the medication. So this should be the treatment protocol. Just try to decrease the dose. That's all. If DAT scan is not available, then once again, you just try to follow this protocol, right? So suspicion, stop the drug, we cannot do this. Abnormals hampering the daily activities, then you follow all these things. Understood? If abnormal movements are just simple, observe the patient. There is nothing harmful to the patient. And yes, we can stop the drug. It is not harmful to life, just like haloperidol or some other antiemetics. It is not threatening to the life. Antiemetics like metoclopramide. Usually we give to patients who have vomiting or nausea in the hospital setup. After taking metoclopramide for a few days or months, patient develops Parkinsonism-like features. If it is because of this, it is not a life-saving drug. So we can stop this. Yes, we can stop the medication. Follow for 6 months by stopping this medication. If patient improves, go for alternate medicine. Other than metoclopramide, go for alternate medicine. If patient doesn't improve, then just follow this protocol. Go for a DAT scan once again. This is very important protocol. I think you have understood this one. What we did was, we were choosing which treatment to go for in a patient drug-induced Parkinsonism. Now the treatment medication. What are the medicines we give for drug-induced Parkinsonism? Usually we have discussed that it is a seesaw, like this. Dopamine and acetylcholine are balanced like this. When dopamine is decreased, like in case of Parkinson's disease, drug-induced Parkinsonism, what happens? Acetylcholine acts predominantly. Now this becomes like this. So acetylcholine is predominantly acting. So we should decrease the effects of acetylcholine. So anticholinergics are the drugs of choice. Anticholinergics, like the drug is benztropine. This is very commonly, very commonly asked question. Benztropine. So they give this scenario, what is the treatment of choice? Immediate treatment is stop the drug. Treatment of choice is give anticholinergics. It is benztropine, right? If patient has some side effects like elderly, the patient here is 86, 84 years. In the question, they also add one point. Patient has urinary retention. So we just miss this point and we start taking the option of benztropine. That is wrong, because benztropine has itself a side effect of urinary retention. Not just benztropine, any anticholinergic has urinary retention. So the next option that you have to choose is amantadine, right? You have to be very cautious reading question. See the age, see the medication patient is taking, see the features. Diagnosis is over. Next, what to do? If the question is regarding evaluation, go for this one. If the question is regarding treatment, just to see if it is immediate treatment or treatment of choice. Afterwards, if is there any topic related to side effects of anticholinergics? Yes, they are given. Don't go for the option of anticholinergics. Go for amantadine. If there is nothing mentioned, go for benztropine as first option. When two are given, go for benztropine. When both are given with this side effects, go for amantadine. So this is about drug-induced Parkinsonism.